Good morning, dear colleagues, dear friends. It is my great pleasure to welcome you all today. My name is Irina Pinchuk. I am Director of Institute of Psychiatry of Taras Shevchenko National University of Kiev, Vice President of Ukrainian Psychiatric Association, Country Director, International Technology Transfer Center, Ukraine, and Head of ISSUP Ukraine National Chapter. ISSUP Ukraine is pleased to invite you to attend the first webinar in a new three-part webinar series on the mental health of youth and substance use. ISSUP Ukraine, in this series of three webinars, would like to raise issues around youth mental health and bring acknowledgement that is connected with substance use. We invite three world-known speakers to talk about depression, self-harm, suicide behavioral, and comorbidity of mental health and substance use disorders in youth. We had 1,495 registered from 108 countries for this webinar. This is a great honor for us as well as a huge responsibility. The first webinar will specifically focus on self-harm and suicide among the young generation. I would like to inform the attendees of the webinar that you can send us your question in the chat during the presentation. Please find the chat in the GoToWebinar control panel. So, it's my honor to introduce Denis Ugrin, Professor of Child and Adolescent Psychiatry from Queen Mary University of London. Professor Denis Ugrin, the floor is yours.
Thank you so much. Irina, let me just quickly share my screen. I think, Olivia, you need to do that for me. Is that right?
We can see it already.
Oh, but I can't. Hold on a second.
I'll just do it again.
Got it. Oh,
good.
Cool. All right, look, thank you so much for the wonderful introduction. Irina and I have known each other for a while, and it's been always a big pleasure to work with you, Irina, on many fronts. This talk is about self-harm in young people and COVID-19. Essentially, what I have no particular interest to declare, except that I wrote a couple of books on self-harm. I always joke that they didn't turn out to be the Da Vinci Code or anything like that, but I still need to declare interest because I get some royalties from them. And also, I need to say that the book on West Ukraine, on Galicia, which I wrote with my daughter, is a subject of particular pride. It has categorically nothing to do with self-harm or COVID, but everything to do with the history of West Ukraine, which is really fascinating. Right, so in terms of today, what I wanted just to tell you a little bit about is overall about self-harm and suicide trends, particularly before COVID. Then to think a little bit about risk factors for self-harm and suicide in kids. Then to analyze the it just gets in the way of this thing a little bit. All right, to analyze the changes in hospital emergency presentations following the outbreak, and then to think a little bit about the implications of what we have found. So, in terms of the world of suicide before COVID, and on this map, you can. This is 2019, just before COVID struck. In this map, you can see that if the country is sort of dark blue-green, then the trend was towards a reduction in suicide. And then if the country is sort of yellowish to brown, then the trend was towards an increase in suicides. And you can see that the world looked pretty different, and in some countries the suicide was going up, and in some it was going down. You can see, for example, that in Ukraine, which is the country I am from, suicides were going up very substantially before COVID struck. If we had a way of asking you questions, I would have asked you the question of why this is. I don't think it's easy to do with this format. So I just tell you that the most likely reason for this is because suicide always goes up following a substantial conflict, war. So if you think about, for example, the number of suicides in the UK, where I'm currently based, then even though the suicide rate has had extreme variation over the last 200 years, then the times of the lowest suicide rates have always been during the periods of war. So during the Second and First World War was the time when suicides were the lowest, and then following a substantial conflict, suicides always go up. And so you can confidently predict that whenever you have a war of some kind, that suicides will go down during the war, but after the war they will go up substantially. We saw a very similar, in fact, picture in the USA. So the lowest number of suicides ever in the US was on the 11th of September. That's something that could have been predicted very confidently. Now, when you look at the world in terms of suicides, then in most areas of the world, you will see that the trend is very clear. You will always have a relatively small number of suicides in the young people, and then there would be an increase gradually of suicides towards the latter parts of life. And in pretty much all countries in the world, you will see that the greatest number of suicides is concentrated around the oldest people. Now, there are a couple of exceptions to this. You can see that in women in South Asia, especially in Southeast Asia, you will see that there is an interesting bimodal distribution of suicide. And so you will see that there are many suicides in very young females, then there is a decrease, and then a predictable increase in the in later life. The other exception to this is Central Europe, especially in males. You will see that there is a very large and steep increase from childhood into middle-aged years, especially in males, and then a relative plateau with another spike towards the end of life. There are many reasons for this, which we could come back to in Q&A if you want to. Now, when you look at Europe, then over the last few decades, we've always known that essentially it's the East and the North that had substantially higher suicide rate than the South, and in pretty much last 20 years or so, Lithuania tended to be the country with the highest suicide rate. But these things do change year on year. But typically speaking, it's the eastern and the northern countries that would have a higher rate, and the southern ones would have a lower rate. Now, we used to think that the reason for this very stark and striking distribution was because people were less likely to record suicides in southern countries. So it was an artifact of recording of suicides. We don't think so anymore. I think even if you correct for all kinds of cultural factors, it seems to be the case that there is a true difference in the rate of suicide, and the Southern Europe seems to have a lower suicide rate, even if you correct for all kinds of other factors. So there is something interesting about the Mediterranean culture, perhaps way of life, that could be interesting to study. Now, going to the UK, you can see that at least in the last 20 or 30 years, they really haven't got much to boast about. You can see that the suicide rate curves are pretty stable, and there was some tendency towards a reduction in suicide from the early 80s until the late 2010s. Now, in the last few years, before COVID, of course, we started seeing a reversal of that trend. And you can see that towards the end, there was an increase in suicides in both males and females, but especially stark in males. Obviously, COVID is going to make some differences in this. I mean, I checked on the 7th of September, we had new data from 2020 released by our Office of National Statistics, ONS. Now, I have to say, I thought about sharing some of this with you, but I then decided not to. The reason for this is because COVID made a very large difference to the way suicide stats are recorded in the UK. So there was a period of time when people who record suicides in the UK were not working. And so there was some very substantial variations in the number of registered suicide in the first half versus the second half, which would have been misleading, I thought. So, but it would be fair to say that we have not seen a very substantial increase that we could have picked up very easily of suicides. There were increases in all kinds of other things and disorders and thinking, but I don't think that we are going to see a very substantial increase in suicides, if at all. Now, when you look at young people in England and Wales, then you can see that even though suicide is the second leading cause of death in young people after accidents, you can still see that the absolute numbers of people who die of suicide is actually relatively low, fortunately, for us. Typically speaking, when you look at 10 to 18-year-olds, including 18-year-olds, then you will see that the number of suicides, the absolute number of suicides, is increasing from very low numbers in preteens to a gradual increase in the numbers of suicides in teens. And of course, 18-year-olds tend to have the largest number. We have not had a year, I don't think, since records began, when we had more than 200 of suicides of 10 to 18-year-olds in England and Wales, and even if you include Scotland, Northern Ireland, it would not have been more than 200. So even though it's a common, relatively speaking, common cause of death, fortunately the absolute numbers are low, which then, of course, creates problems in terms of predicting suicide. It's one of the most difficult things to predict in medicine. So now moving on to looking at various groups, you can see that, if anything, we have something interesting to report in females. So when you look at different age groups of females, you can see that, if anything, there is an interesting downward trend, certainly from the early 80s, especially in middle-aged and older women. So there is something interesting to say about that. You can see that from late 90s, the numbers have been fairly static and there is no further decrease, except in the youngest females, so 10 to 24-year-olds, where there is a tendency towards a substantial increase in suicides, and we will come back to this. It's a very interesting thing. I will just say to you that in 2019, before COVID, the number of suicides in the youngest female was the highest ever recorded in the UK. There's something very worrying happening with our teenage girls and young adult women who, historically having had a very low rate. They now have a very, very high rate, the highest ever recorded. Now, when it comes to males, things are not as interesting to report. Obviously, they've been fairly static. The only, I suppose, piece of good news here is that when you look at the gray line, which is the oldest 75 plus males, they have always been the demographic with the highest rate of suicide. We have made a difference in that group, which is wonderful to see. So they are not anymore the demographic with the highest rate of suicide. They're in the middle, and it's the middle-aged men that have the highest rate of suicide in the UK now. When we think about the day of the week, that's Mondays that have the highest rate of suicide in both males and females by a long margin. The difference in females is actually even more stark than in males. I used to work in Abu Dhabi and Dubai for a while, and I have to say that the interesting thing there is that it seems to us that the day with the highest rate of suicide there is not Monday, of course, because that's not when the weekend is, but it's Sunday, which is the first day of the working week. Now, there are certain groups of people and young people that I wanted just to highlight to you in terms of the risk of suicide. One such group are people with autism. The ASD stands for autism spectrum disorders. Now, this is a relatively new finding. We've always thought that these people have a very high rate of suicide, but this is based on a Swedish cohort. And you can see that overall, people with autism have about 7.5 times higher rate of suicide than people without autism. But the most interesting part of that study was that it really depends on whether or not people have intellectual disability, i.e. low IQ. So people with normal IQ or high IQ with autism have by far the highest rate of suicide of all of the people with autism. So if you have intellectual disability, your risk is 2.5 times. If you don't have it, it's nearly 10 times the rate of the general population. So interesting differential there, which goes against many other populations. Now, when we think about methods of suicide, then in the UK, hanging now is the top method of suicide. You can see that traditionally, until about mid-2000s, females were much more likely to kill themselves by self-poisoning. But in mid-2000s, you can see that there was an overlap when hanging and self-poisoning was about equally distributed in the male and female population. And then since about 2012 or so, you can see that hanging has now taken over, and there are more females dying of hanging, just like there are more males dying of hanging in comparison to any other method. And self-poisoning is going down. Again, it's a very interesting thing to discuss, but again, we can come back to this in Q&A if people are interested about that. So again, just to have a final look at males who are young. Obviously, I'm a child psychiatrist, so this is of greatest interest to me. There was a peak in the 80s and the 90s. We were hoping that we were seeing this very encouraging trend towards a reduction of suicide rate in males, in young males, which unfortunately has stalled and has now been reversed. And when we look at females, as I've mentioned to you before, the younger females, there was a fairly flat rate, but in 2019, just before COVID, we saw really the highest rate of suicide in this age group ever recorded. There is something we need to really be thinking about in younger females. Let me just also tell you that this is not just about suicide, this is across the board. When we look at pretty much any psychiatric disorder and self-harm, all of this is going up in young females in the UK and many other Western countries. Moving on to self-harm. Self-harm is obviously a lot more common than suicide in young people. By self-harm, here I mean self-injury by self-cutting, for example, and self-poisoning by, for example, an overdose of tablets. Now, you can see that in 2006, actually 2004, when the data was collected, we saw that something around 10% of children and young people will have self-harmed by the time they finished school. So about 15%, give or take, girls and about 5% boys. Now, obviously, since then, we've had many surveys, none, by the way, as comprehensive as this one called the case. And the sensible estimates of lifetime prevalence of self-harm are probably close to 15 to 20% now overall. So they have increased very substantially. But the reason why I'm showing you this particular slide is because you can see on this slide how variable the prevalence of self-harm actually is in different countries. And sometimes it's really almost hard to believe. Like if you look at Holland, which in that survey had a very low self-harm rate in both girls and boys, and then their neighbors, Belgium, which is really just around the corner, and half of the country speaks the same language, and culturally seem to be fairly close. They have one of the highest rates of self-harm. So there's a really interesting difference there. Let me just also tell you that I don't think these differences could be explained, for example, by some sort of problems with translation or interpreting, because it was the same question, really well translated and adapted to the local culture. So yeah, I think there are real differences in self-harm prevalence. There is no doubt about that. And also just to say that Holland, which you can see here, has one of the lowest self-harm rates probably in the world, then again, that doesn't seem to be an artifact to me, in the sense that if you look at child health surveys in Holland, they often indicate that the population is, relatively speaking, quite healthy. There's something interesting to learn from them. Now, again, need to go back to the idea of special populations, in this case, ASD, autism. Again, self-harm is very, very high in young people with autism, probably close to 50%. And the nature of self-harm, I think, is quite different from people without autism. And the predictors of self-harm in that population are sensory problems, the insistence on sameness, so when sameness is disturbed, impaired cognitive ability, and social functioning. When we look at self-harm from the point of view of primary care, so that would be family doctors and people who work with them, then you can see that people who come with self-harm to primary care, to family doctors and nurses, then you can see that, again, you see the highest rate of self-harm in females and in young females as well. There is some tendency over many years to an increase in the number of people who come with self-harm, especially so in females. And now when we look at self-harm globally in young people and children, then you can see that in Europe, as I mentioned to you, the suicide is the second leading cause of death after accidents. When we look at global, then that is also true for females, for young females. You can see globally that maternal conditions are number one. So young females who die in labor, that's the most common cause of death in that population, but self-harm, i.e. suicide, is the second leading one. And then when we look globally at young people who are male, then it slips into the third place. So injuries, accidents are number one, then violence, and then self-harm. Interestingly, in America, suicide was the third leading cause of death in young males also, until relatively recently, superseded by accidents and homicides. Now it moved up to the second place. Now, is there anything we can do about self-harm? Well, let me tell you that up until about 2015, my answer to that was no. There was really nothing evidence-based that we could do about self-harm. In 2015, my group published this meta-analysis, which for the first time told us that we are probably not wasting our time with kids with self-harm. And you can see from this meta-analysis that overall psychological therapies seem to be just about effective as compared to controls. Now, for those who may not be very familiar with this method, let me just explain to you what it's about. So you can see on the left, where it says different names and years, that is individual studies, and the first author of the study and the year was published. All of these studies are randomized controlled trials, or RCTs, which means that you have a group of young people and you randomly assign them to either psychological therapy or some sort of a control. And then you compare their outcomes. So the outcomes are graphically represented on the right, and you can see that there is like a blue dot, like here or there, right? So if that blue dot is on the left of the vertical line, it means that the psychological therapy in question overall was more effective than doing nothing or doing some sort of a control. If it's on the right, then overall doing nothing was better than doing psychological therapy. And the horizontal line around the blue dot indicates how confident we are about that finding. So if the horizontal line crosses the vertical line, it means that we cannot be certain, statistically speaking, whether psychological therapy was better or worse or the same. And if it doesn't cross, like here, then you can be confident that psychological therapy was better than doing nothing, doing controls. And so overall, you can see that there are some therapies that seemed to be a lot more clearly associated with a better outcome, i.e. fewer number of kids with self-harm. And there are some therapies that tended to be harmful, i.e. kids tended to self-harm more in these psychological therapies than if you did nothing. Just to say that at the moment, the psychological therapy, which now has 3 independent RCTs, studies, all of which indicate a reduction in self-harm, as a therapy called DBT, which stands for dialectical behavior therapy. Now, in kids, and also there are many studies in adults too, this is in children. So just to say that if there is one therapy that I would recommend developing and training people and supervising people, is DBT for self-harm. Other therapies with some potential promise are CBT, cognitive behavior therapy, and MBT, which stands for mentalization-based therapy. Let me just tell you that now there is one positive and one negative study in each of these, in CBT and MBT. The only therapy with no negative studies at the moment is DBT. All right, so this was in 2015. In 2020, we did an update with my colleagues in Austria. That work was led by my colleague called Paul Trina and his postdocs, and we have found, I think the conclusions are still hold true. So overall, psychological therapies tended to be more effective than doing nothing. DBT obviously still stood out as the best option. When it comes to, so this is about self-harm, right, specifically. Now, when it comes to ideation, i.e. thinking about self-harm, then both DBT-A and one more therapy, which is called family-centered therapy, were effective. So we did not find that family therapy was effective to reduce self-harm, but we did find in this work that family therapy was actually effective in reducing thinking about suicide. So what about risk factors for self-harm? Most of you will know these things quite well. I just wanted to focus your attention on a couple of things that are relatively new and perhaps are not as well known as other factors. So ASD, as I mentioned to you before, stands out. ASD, autism, is one of the strongest predictors of self-harm in kids. Said about 50% of kids with ASD will self-harm at some point in their life. The other, I think, relatively new issue that you may not be familiar with are young people who are not heterosexual. That's a relatively interesting finding, relatively new. They seem to have significantly higher rate of self-harm. And then just wanted to say that perhaps one should really, I don't know how often you do this, but perhaps one should really inquire about the history of self-harm in the family. So that is not a new factor, but I know from my junior doctors that they don't often ask about that, and it's something that is of interest. So one really should inquire about self-harm in the family of the child when you assess them, and also in their surroundings, so their friends that they hang out with, whether they self-harm. That's something that is important and could be an important risk factor to determine. So then moving on from thinking about suicide to suicidal attempt. So what predicts that? So who will move from thinking about suicide to actually attempting suicide, i.e. self-harming? Well, these are the risk factors for that. Just wanted to maybe specifically focus your attention on hopelessness. It's something that, for those of you who were trained in child mental health, you will know that hopelessness is one of the strongest predictors of attempted suicide and suicide in children. A relatively new risk factor for that is body dissatisfaction. That is something that my colleagues from our body dysmorphic disorder service speak to us about, often saying that actually kids with body dysmorphia are at a very, very high risk of thinking about suicide and then attempting suicide and possibly also dying. And then moving on to risk factors for completed suicide, we've mentioned obviously sex differences, male versus females. Again, just to focus your attention on a couple of things here, hopelessness stands out as the strongest psychological risk factor. And then also just to say that we now know that family history of suicidal behavior is a very strong predictor of completed suicide in kids. So that's worth inquiring about. Moving on to emergency presentations. So about maybe 20 years ago, when I started working in child psychiatry, we were thinking that about 10% of kids will come back to the emergency department with self-harm. And now the rate is probably closer to about a third. So 1 in 3 kids will come back. And if you follow kids for a long time, say 10 years or more, then about 1% of them will unfortunately die. And if you look at that 1%, then half of these kids will die of clear suicide. The other half will die of other causes, most commonly accidents. But if you look carefully at some of these accidents, it is almost certain that there are many suicides that are misclassified as accidents. The things to also focus your attention is that violent methods of suicide attempts, such as attempted hanging or jumping from heights, are associated with about 8 times greater risk of dying by suicide than non-violent methods, such as ingesting tablets or poisons or cutting your skin. One thing I wanted also just to mention to you about a relatively interesting and new risk factor. We had a special issue of JCPP, which is a key journal in child psychiatry, in 2019, and we published this. I was actually co-editing this this issue with a colleague of mine called Professor Azanov from UCLA, and I just wanted to show you this very interesting study, which I really enjoyed reviewing and editing. So we have known for a long time that kids who are isolated tend to have a higher risk of suicide and self-harm. But on this particular graph, you can see on the right, now the red dots are kids who have a history of attempted suicide. And you can see that not only are they somewhat isolated from other kids at school, but also they seem to be aggregated together. So, we've known anecdotally that kids who think about suicide and attempt to kill themselves are isolated and possibly talk to each other more. But this is a very interesting graph that shows that, how these connections actually work, and you can see that it is undoubtedly true that kids who think about suicide cluster together and are isolated from other kids. In terms of risk assessment, obviously we are not terribly good at assessing risks. You know loads and loads and loads of risk factors at the moment, but none of them are particularly, I must say, good, because the absolute risk of suicide is so low. Then even if you have good risk factors, they increase our ability to predict only slightly. There are some interesting new ideas around this. I'd say that if you have a bit of time, I would really encourage you to check out this website here. It's a colleague from Harvard called Matthew Nock, who does really very interesting stuff in this field. He's got these ways of making implicit associations between concepts such as me, I, mine, and life, living, enjoying life on one hand, and then death, dying, and self-harm on the other hand. And it measures your reaction time, which is really quite a novel and interesting way of measuring risk. Do check it out, very interesting. You actually measure your implicit association not just for self-harm, but for a number of other things, like whether you like Donald Trump or not, whether you like certain types of people or not. Anyway, so what about then COVID? Well, COVID is something that probably will have a major impact on mental health of kids in general for many years to come. Some of these things are of interest to consider. Anxiety and fear related to the pandemic undoubtedly have increased. There've been an increase in certain risk factors for self-harm and for other disorders such as isolation and loneliness, and probably an increase in domestic violence, alcohol consumption, especially in adults, but also in kids, interestingly, exposure to social media and stuff of this kind, and bereavement. You can see that it'd be a miracle if with all of these risk factors we saw no impact on child mental health at all, which indeed we have seen. And some of these risk factors may have been counterweighed by, for example, things like reduced school-related stress or exam-related stress in some kids, but that's certainly not in all. So what we were curious about is to find out a little bit about the impact of COVID, especially the first wave of these pandemic-related restrictions, on what happened to kids in emergency departments in hospitals. We call them accidents and emergencies in the UK. In America, they call them emergency rooms. But you get the idea. So this is what happens to young people who come to hospital with significant self-harm and seek urgent medical help. So what we did was we compared March and April 2019, i.e. a period before COVID, with March and April 2020, which was the peak of the pandemic-related restrictions in many countries. We only looked at kids under 18, and we only looked at psychiatric emergencies, i.e. people who come to emergency departments with significant self-harm. We did 10 countries. For that, you can see quite a nice mixture of countries in Europe, Middle East, and the Gulf. What we have found in that study was that the total number of emergency presentations between 2019 and 2020 was actually substantially and significantly reduced in most countries that we checked. We also found that the proportion of self-harm presentations out of all emergencies, psychiatric emergencies, also increased from 50% in 2019 to 57% in 2020. So the overall number of emergencies reduced, but the proportion of kids with self-harm actually increased. We saw this in most countries that we have looked at, in most sites. There were a few exceptions. Turin, for example, was one of them, and Livingston in Scotland was another. But overall, we saw this pattern in most countries and centres. What we also found was that the number of young people who had presented the emergency departments with self-harm before has actually increased. So kids who'd been exposed to emergency departments before had, saw a smaller risk of not seeking help than the ones who'd never been. That's an interesting finding in its own right. We also wanted to look at whether kids with previous self-harm in the community were any more likely to come, and we have found no difference there. Amongst those who came with self-harm, we were wondering whether the number of kids with significant, with severe self-harm was actually higher than the ones before COVID. Again, that was our hypothesis, which wasn't confirmed. So we did not see an increase in the proportion of kids with severe self-harm, i.e. the kind of self-harm that required, for example, intensive treatment or a long admission to a hospital. We did not find that, except for maybe a couple of places like Edinburgh, but overall, no. We have found, in accordance with our hypotheses, that the proportion of kids with emotional disorders such as anxiety and depression was higher in the COVID year than before COVID, by about 1.5 times. And we also found that during COVID, during the first wave of the pandemic, the proportion of kids admitted to overnight in the hospital was actually lower. So I think doctors and nurses were less likely to admit kids overnight during COVID than before COVID, which might have implications for the kind of care they were getting. And then there were a few notable negative results, which I wanted just to share. We found that kids from deprived areas were no less likely to seek help in A&E than kids from affluent areas, with one exception to this. If you really look at the indices of deprivation, which in the UK we have very, very detailed ability to actually look at this, then even though kids from the deprived areas were no less likely to seek help than kids from affluent areas, then if you look at the bottom 10%, i.e. the lowest decile of kids from the most deprived areas of all, then those were the ones who actually had a lower rate, lower chance of seeking help. So there is something about focusing not just on kids from deprived areas, but also from the most deprived decile, like 10% of all of these areas. We did not find, interestingly, that kids from ethnic minorities were any less likely to seek help if you correct for deprivation. We did not find any differences in the chances of kids being offered follow-up appointments. So in the UK, for example, you're mandated to offer a follow-up appointment to kids within 7 days of them coming to hospital with significant self-harm. Again, we were worried that they'd be less likely to be offered a follow-up appointment, but they were not. And also, they were no less likely to attend the follow-up appointment. Admittedly, we allowed for not just face-to-face, but also remote appointments. So there was no difference there. And then we just were wondering whether, this very substantial decrease in the number of kids coming to A&E with self-harm was reflected in inpatient admissions. So perhaps we were admitting more children to inpatient care, psychiatric care in the UK. We looked at that and we found, again, no difference, no evidence of that at all. If anything, the number of admissions also very dramatically decreased to 249 in April of 2020, which was the lowest number of kids ever admitted for inpatient psychiatric care in England since records began. So what are the implications? The implications are that we have found, a very substantial reduced emergency hospital presentations in kids during the first wave of 2020 of COVID. There is no reason to believe that it was driven by a genuine low incidence of these emergencies, and almost certainly is to do with less frequent help-seeking behavior. When we asked children, by the way, about this, then there were two groups of reasons why they told us they were less likely to come. One reason was that they were scared of getting the virus in the hospital, and the second reason was that they were worried about diverting services from people who needed it with COVID onto themselves. So it's a mixture of egoistic and altruistic reasons, like most people have anyway. And really, just to say that perhaps the most important implication of this, which was really very important to understand, was that initially we thought that investing more money in hospital-based emergency services was a good idea. And indeed, a lot of trusts actually invested a lot of money in this, including my own trust. But then in the light of these findings, it became clear that investing in emergency hospital admission services was not a good idea, And in fact, because a lot of kids were staying in the community and not seeking help in the hospital, then what we should have done and what we have done subsequently was actually investing a lot more money in developing intensive community care services in the community rather than in hospitals. And this is what happened subsequently, and this is perhaps the most important implication of this research. I think I will just finish at that, just to allow a bit more time for questions. So Olivia, if you're listening, could you kindly make me appear large on the screen, and let's have a look at some questions.
Thank you, Professor Denis Ugrin, for a very interesting, useful presentation. Now we have some time for questions. We would like to thank our participants for submitting questions. The questions number 1. Can we say it fluctuates in reporting before and post outbreak? The rate has been higher as compared to during lockdown.
Right, so that's a good question. Thank you so much for that. The issue, Olivia, is it possible to see the audience or not? Because I'm just seeing still the screen. With...
If you, your presentation's not showing, so if you close your presentation, you should be able to see Irina. You can't see the attendees, but you'll be able to see Irina.
All right, maybe it's at least nicer to see a human being than. Right, let me see. Yeah, I'm not sure I still see her, but anyhow. Anyway, it doesn't matter. So, all right, look, so that's a good question. The issue though is this. We have seen a substantial reduction in the numbers of kids who were coming to emergency departments in many different countries during the first wave of the lockdown, i.e. in March and April 2020. We are now, literally just now got the data from about 20 or 30 countries, and it's from 2021, from March and April 2021. It appears to us that the number of kids coming to emergency services now, this year, is dramatically higher than in 2020. So we probably are seeing a increase, like a rebound increase in the number of kids coming to A&E this year. We don't know, I haven't looked at the data yet, but I will, and we'll publish that. We don't know if that rebound is actually higher than in 2019, i.e. the actual number this year would be higher than before the COVID pandemic. But it's certainly, without a shadow of doubt, it is undoubtedly significantly higher now than the same time last year. So this initial reduction in the number of emergency presentation has now stopped, and we are seeing a substantial increase in the numbers coming through. Just also wanted to say that there are some interesting and unusual presentations that we see, certainly in London. I haven't looked at many other places just yet, but we certainly seem to see a lot more eating disorders in London, which is something that I would never have predicted before the COVID. And we also seem to see a lot more kids with Tourette's, with tics, now than before. Again, something that seems to be counterintuitive, and it's something that I would not have predicted. I would have easily predicted an increase in the number of kids with anxiety during COVID, but not with anorexia, and certainly not with tics. So there are some very interesting implications of that that are interesting to think through.
Okay, thank you. The next questions. Norway and Finland suicide rates are higher than many others. Your comments?
Well, all right. So I mean, okay. So let me just think about this for a minute. So it is true that Northern European countries and Eastern European countries have a substantially, significantly higher risk of suicide than Southern countries. Now, here's a very interesting thing why this should be the case. Now, the answer to your question is I do not know why this is. But there are certain factors that might be important. I need to just say, for those who are interested, if you look at my YouTube channel, you can just search Dennis Ugrin, you will find it. You will find quite a few more ideas than a few more videos about this. But overall, I think the kinds of factors that may be of interest is that it is probably true that many southern countries are more cohesive and have a more cohesive family units, including extended family. And social support is probably one of the most interesting factors, and perhaps one of the strongest factors that prevent self-harm and suicide. So being part of a family and being part of a community. As we see less and less cohesion in certain societies, then self-harm and suicide goes up. And so that may be an important factor. There are also important factors to do with lifestyle, quite possibly to do with diet. I'm not sure about that, but it may be an interesting one. There are undoubtedly, there are very important factors to do with alcohol consumption, especially in Eastern European countries. And for those who are interested, you could see an incredible reduction in the number of suicides in Soviet Union in mid-80s, despite economic hardship, when we had this strange period of enforced sobriety. So there are many factors that are at play, but if there is one thing that I would recommend, then that would need to be really an issue to do with social cohesion.
Okay, the next questions, very interesting. What is the solution of this suicide problem? How it can be overcome?
Well, we only have 1 minute to go, so I won't be able to tackle this very important question. I would say that if there is, I mean, there are so many factors that could be done about this, but if there is one thing that we should focus on, it's the social connection, social support, and social cohesion of our communities.
The next, maybe it's continue this question. Do countries implementing national suicide prevention strategy have lower suicide rate, suicide attempt?
That's not a very clear. I mean, the thing is, I mean, obviously having a national strategy is a really good idea, I think, because at the very least, it creates a focus on suicide and self-harm. It's something that people think about, and something that focuses the service development. But it's not enough. It's definitely not enough. It's something that requires not just document, not just the plan. It requires whole community effort And I mean the entire community, not just certain parts of it. The entire community needs to think about this and focus their efforts together. All agencies, voluntary sector, faith groups, schools, pediatricians, scouts, and all of these things need to really think together. And that really has the best chance of having an impact on this big problem. I think we're out of time. Is that right, Olivia?
Yes, that's correct.
Maybe, yeah. Next question, is there any data on people, males and females living with disability, physical or mental, in relation to suicide? Would information from this group differ from that of the general population?
Yeah, I think, Irina, that has to be the last question, I suppose, right? Because we're really out of time. So I will just say here this, that there are different, I mean, obviously disability is not one thing. It's a complex and very heterogeneous group of individuals. If there is something that I wanted to focus your attention on, then it would need to be kids and people with autism. Now, they have an incredibly high risk of self-harm, 50% at least, and also they have a very much substantially higher risk of dying of suicide, about 10 times, well, about 10 times if you have no intellectual disability. The relationship here is complex because those people who have profound or severe intellectual disability tend to have not as high suicide rate, especially if they look in managed environment. The people who are at the greatest risk of suicide are people who essentially live independently, have a very high risk of self-harm, of depression, of anxiety, of thinking about suicide, and then having access to means of suicide. So of all of the people with differences, I would say that perhaps the group that I would focus the greatest amount of effort and time are people, and especially young people with ASD, who live in the community and who develop anxiety and depressive disorders in their teenage years and late and early adulthood. So I would say that if there is one group that requires a lot more time and treatment, that would be the young people with ASD who develop emotional disorders in their teenage years.
Thank you. I would like to thank everyone for participating in our webinar. Special thank you goes to Professor Denis Ugrin for the great contribution on this event. Looking forward to meeting you soon at the next ISSUP Ukraine event in October. Also, I would like to thank our technical support, Olivia. Thank you.
Thanks, everybody, and do keep in touch. It was, great questions, and speak later.
Bye.